I think that we can utilize these 5-10 minutes for the general discussion. So eventually, the question to you will be answered later. So let's talk by. We have De Paulis, okay, and Canehia. Please.
Please.
Can you make your general conclusion?
It's so difficult for me. Professor Lezoke, thank you very much for your giving me this precious chance. And I think I was deeply impressed by the very excellent technique of each speaker and each doctor. And I think it's quite difficult to analyze the clinical outcomes when it comes to the resection technique from inside compared to that in the resection technique which is going from outside of the organ. Because from the inside, it can be categorized as a tailor-made surgery, and it depends on the skill of each doctor. So I think it's also very difficult to standardize this tailor-made surgery or tailor-made resection technique and disseminate this technique worldwide in the nations or in the world. So I think analysis is also very important, and at the same time, we have to focus on how to level up the rest of the physicians, because we have seen the data made by only champions or masters today. That's what I wanted to say. Thank you.
There is any other comments? Any question to the last speaker? Yes, Arito.
If I can, Professor Lezoke. Dr. Saito, it's extremely strange to see how keen you are in supporting your technique, but that actually the en-bloc resection rate is far from 100%. This is probably the reason why recently, already 2 years ago, a Dutch trial started comparing not ESD to TEM, but EMR piecemeal to TEM. Because they recognized that the very much effort that you probably did not mention of hours and hours of procedure did not turn out to be an advantage in terms of radicality because of the high rate of marginal filtration of the specimen. Can you comment on that? Do we have data that really show that you reduced the local recurrence incidence by performing ESD instead of EMR?
Thank you very much. So the data we show today's presentation is relatively old data. So it is the very important, the one important thing is, of course, the learning curve for ESD. Because the first ESD is very technical, difficult, but now recently we have developed many ESD devices and we understand how to do ESD safely and accurately. So now if you have the learning curve, the en-bloc resection rate will be reached to almost 100%. And R0 resection rate also become to 100%. However, we understand it's very difficult to widespread use of ESD outside Japan. Maybe we need to do the much more hands-on course, or such kind of procedure is very important. And of course, we should from now compare not between conventional EMR and ESD, because if we compare between EMR and ESD, ESD become a very long-time procedure. But the cases now we have treated, we treat using ESD technique is quite different from the cases have been treated by EMR. The many cases we are now treating by ESD technique had been treated by surgery. So that's the point.
Thank you.
I think that we can conclude this section. We have seen very interesting paper, and we have seen also what the future will be also in some aspect for the endoscopic treatments. So I think that I like to congratulate with all the speakers, and we will meet again, I think, in the next year in, what is the next meeting? In Singapore. Okay.